Good afternoon. Thank you very much for giving me this opportunity to come here and interact with you. This is supposed to be a debate, and I'm going to present a view for VATS being the modality of choice, so the primary treatment in pediatric empyema. I thought we were talking about empyema, although in the topic it's given as pleural effusion. I mean, no one talks about VATS in pleural effusion, so I'm talking about VATS in empyema. So first of all, let's clarify a couple of terms. What is VATS? This is an acronym for Video-Assisted Thoracoscopic Surgery. It has been used to treat a wide variety of thoracic lesions such as empyema, lung lesions. I mean, we basically put in a camera into the thorax and then we do what needs to be done. So we've been doing VATS for CPAMs, tracheoesophageal fistulas, diaphragmatic hernias, etc. What it actually does is reduces the morbidity of an open thoracotomy. What is empyema? We all know what empyema is. It's a collection of pus in the pleural cavity. It's often secondary to pneumonia and is classified traditionally into three stages, 1, 2, and 3, exudative, fibrinopurulent, and organizing stage, which we call the pleural peel. These stages correlate with the duration of the disease. But we must remember this is a continuum. So the disease starts with the pneumonia, then the effusion, then the empyema starts, the fibrinopurulent exudate, which then gets organized, and so on and so forth. So although we sort of arbitrarily divide it as early, intermediate, and late, it's basically a continuum, and we have a lot of difficulty in figuring out where the patient is in that continuum. There is really no controversy in the management of stage 1, which is the early exudative phase. We've got some purulent material in the pleural cavity. The fluid has a pH of less than 2. It's sometimes frank pus. Everyone agrees that we should drain this, and we drain it by doing what is called a tube thoracostomy or an intercostal chest tube drainage, and obviously we are giving antibiotics. There are two possible outcomes. One is resolution. Most of the patients will resolve, or some children have a persistence and what we call loculation, and they go on to the stage 2. The management of stage 3 or the organized stage of empyema is also not in any question or doubt. We know that there is a pleural peel, as you can see in the CT, a very thick peel which is enclosing the lung, and the lung cannot expand. This has to be removed, and this is not possible by anything else other than surgery. Traditionally, we were opening the chest and doing a decortication, as you can see in the intermediate picture. That's the kind of stuff that we take out, thick, hard stuff encasing the lung. We traditionally would do it with thoracotomy, but now, increasingly, we are doing video-assisted thoracoscopic surgery and decortication. It's a lot more difficult, but it can be done. So essentially, the debate is all about this. What should we do for children who have this loculation or little areas of pockets of empyema, or what we call stage 2 empyema? Well, there are now two options. Either we do VATS, because we know that if you just put in a chest drain, the failure rates are pretty high. And we know that this happens in about 20 to 33% of cases. Or the alternative, and I'm sure my next speaker will talk about it, is chest drain with fibrinolytics. So why would we want to do VATS? The first and most important thing is our condition. In our condition, we really don't know when the disease started. So it's not dependent on the stage of the disease. You can do VATS for any patient. We get a direct vision into the pleural space. And in fact, this video-assisted camera putting in was actually started as a method of actually seeing what the empyema looked like. We can lyse all the adhesions that are there. We can take out all the fibrin flakes, and we can confirm lung expansion on the table. We also put the chest tubes under vision. We know exactly where those chest tubes are going. It is traditionally done with 3 ports, but now we are getting a uniportal VATS as well, which obviously reduces morbidity further. Let me see if this works. This is what we typically tend to do. As you can see, there's a lot of pus. It looks like a abscess cavity, and we are irrigating, and we are slowly taking away all that stuff which is inside the pleural cavity. It's a pretty messy surgery, not that we love doing it, but it works very well. As you can see, that's the parietal pleura, which is thickened. The lung is lying medially or on the left side. Let me show you what else we can do. What we can do is we can do what is called early decortication. And as you can see, this is the visceral peel on the lung, and I'm gently teasing it off with instruments away from the lung so that the lung can actually expand. This is the stuff that actually will solidify into the pleural peel if I leave it there. And like I said, it's not pretty. There is some amount of blood that goes through, but it's very effective. So This is a typical case that we get. This is a child who came to us from, I think, Shiliguri. She's had a chest tube put. As you can see, the lung is trapped in fluid, and there are cavities in the lung as well. And after VATS, this is the entire amount of stuff that we took out. It was almost filling the entire chest, all of this fibrin flakes. So what evidence do we have to back VATS? Well, VATS has been around for a long time now. And initially, we started doing VATS as an alternative to just chest tubes. Later on, there are papers that suggested that early VATS, without even putting in a chest tube, might be the best thing to do for empyemas. We know that it's pretty safe. Mortality rates from VATS is very, very low. Morbidity is low because we don't open up the chest. So essentially, it had become the treatment of choice for stage 2 and early stage 3 disease. For stage 3 disease, which is old, thoracotomy still was possible. Treatment failures are low, and we know over a wide series of papers, secondary procedures, that means a redo or a conversion to thoracotomy, is low in 5 to 7%. And we know definitely the stay in hospital and the total duration of antibiotic usage goes down. So the question is, as your pediatricians, you would ask, why not fibrinolytics? They get good results as well. Well, as of now, there are certain issues. First of all, we don't have too many studies from India. I don't know why. Not too many people are doing it. There are concerns that the studies in the West which show fibrinolytics being a good alternative suffer from these little problems. First of all, most of their cases have staph pneumonia. We get a lot more staph aureus empyemas. The pus is traditionally thicker, more difficult to remove. In general, European studies or Western studies, the patients have better nutritional state. Our kids are not so well off. There is also some controversy about what agent to use, what is the dose regime. We are not certain about these things. In addition, there are the adverse effects of medications that we use. There's fever, chest pain. This we've seen quite a lot. Bleeding is pretty uncommon, but it does happen into the pleural space or elsewhere because we're using things like streptokinase, tissue plasminogen activator. Expense. Alteplase is TPA, which is the safest agent that can be used, and it's pretty expensive. For a while, it costs $50,000. In addition, most of these children have an intercostal chest drain already put for drainage. So it is actually pretty difficult to instill the agent, keep the drain closed, and then take it, drain it out. This is best done through a small pigtail catheter, which is what most of the studies in the West show us. They do an ultrasound and they put a small pigtail catheter into the collection, and then they use the fibrinolytic agents, which generally is not the case in India. In addition, most of the studies will show that they have used routine negative suction. Now, for some or the other reason, this is not a common practice in India. When there's a child with pleural effusion, we put in a drain, but very rarely do we see somebody put negative suction to help expand the lung. So this is not something that we have been doing. So it's, the studies that show us that fibrinolytics work are not strictly replicable here. In addition, for us, what we've seen here is that most of us can't figure out when the disease started and how old is the disease process, because patients don't typically come into the hospital very early. They've been treated here and there, antibiotics, some courses, until a complete whiteout is noted, and suddenly then they come into the hospital and we get pus. So we really do not know whether this is stage 1, stage 2, or early stage 3. So, and in addition, if we've tried fibrinolytics and after that we do VATS for failure, it is more difficult in certain studies. It shows more difficulty in getting rid of all the all the pus, and these can lead to more thoracotomy, so the total duration of treatment can increase. Finally, because there's been a lot of use of fibrinolytics recently, this is a fairly recent study which analyzed more than 3,300 cases of empyema in children from the US. And they've seen that maybe we've started using too much of fibrinolytics, and maybe we should step back and take a look at what the studies really say. And they've written, although national trends favor chest tube and fibrinolysis, primary VATS is associated with a shorter hospital and PICU stay and a lower requirement for mechanical ventilation. So we've got to try to identify more patients who benefit from, let us say, early VATS as compared to fibrinolytics, rather than saying one is better than the other. There is basically ample room for both to coexist. I'll just give you an update of what we've done. In the last year or so, we've done 11 cases. There have been no conversions as thoracotomies. There has been one patient who had an air leak which needed a period of prolonged drainage, that is for 10 days. Majority of the patients had tube removals on day 5 of surgery. We needed 2 blood transfusions. And majority of the patients that we got had disease for more than 7 days in any case. And the one that I showed you had the disease existing for more than 3 weeks. So in conclusion, VATS is time proven. This is the level that we have to reach if we want to do something else, for example, fibrinolytics and intercostal chest tube drainage. And until we reach that place where VATS is the definitive answer, we should continue to use VATS as much as possible. Thank you.